In this seminar, we will talk about pharmacotherapy in ADHD, or otherwise called Attention Deficit Hyperactivity Disorder. Quick recap. ADHD is the most common neurodevelopmental disorder. Impairments of ADHD persist well into adulthood. Untreated ADHD reduces the lifespan of about 12 to 13 years. ADHD causes academic and occupational failure or decreased performance. ADHD increases risk of injury, criminality, suicide, substance use, societal disability, and other psychiatric comorbidities. The treatment of ADHD are fivefold. Medications are the first line of treatment for ADHD. Second is behavioral therapy. Third, supplements, diet, and exercise. And computer-based systems. And finally, treating comorbidities that's often associated with ADHD. Today, we are going to talk about just medications in ADHD. As you can see, the core symptoms of ADHD are three: inattention, hyperactivity, and impulsivity. The pharmacological agents are the first line. They are called stimulants. First one is methylphenidate. The second one is amphetamine salts. Here it is lisdexamfetamine. So there are three groups of medications. One, stimulants. Under stimulants, there are two: methylphenidate salts and amphetamine salts. Non-stimulants, there are three. Most commonly used is atomoxetine, otherwise called Strattera. Second one is viloxazine, otherwise called Colbury, and alpha-2 agonist. It's available in clonidine and Intuniv or Guanfacine. And there are other psychiatric medications are used in the treatment of ADHD. Those are bupropion and buspirone. So in patient with ADHD, the neurotransmitters secreted from presynaptic neurons into the synaptic cleft. This one is presynaptic neuron. This is cleft between presynaptic neuron and postsynaptic neuron. Normally, neurotransmitters are secreted into the synaptic cleft, then acts on the receptors, thus promotes the information from one neuron to another. In patient with ADHD, as you can see, there is a paucity of neurotransmitters in the synaptic cleft. So when you give a methylphenidate, what does it do? It blocks the reuptake, dopamine reuptake, as well as norepinephrine reuptake from the synaptic cleft. As a result, the neurotransmitters present in the synaptic cleft so that it can act on the postsynaptic receptors. Methylphenidate blocks the reuptake of norepinephrine and dopamine. Thus, it increases dopamine and norepinephrine in the synaptic cleft. That has a stimulant effect on brain, mainly in thalamus cortical areas. The side effects of the methylphenidates are many. It can decrease appetite. It can cause insomnia. It can cause nausea, vomiting, dyspepsia, abdominal pain, weight loss, anxiety, dizziness, irritability, affect lability, tachycardia, and increased blood pressure. I want to show three important group of side effects. Invariably, all the patients will have nausea, vomiting, dyspepsia, abdominal pain the first week or first 10 days. Then it will go away. At the evening time, in case of extended release preparations or after the immediate release preparations, when the effect wanes off, They can have irritability and affect lability. Sometimes it is so severe, so sometimes we have to stop the methylphenidate. These side effects also will go away in 1 or 2 weeks. So it will have effect on the decreased appetite, weight loss, tachycardia, increased blood pressure, and insomnia. Decreased appetite happens invariably in all the patients. As long as there is no weight loss, we can continue to give the medication. Even this effect will go away after a few months of continuous exposure to methylphenidate. The effect on the tachycardia and increased blood pressure are minimal, needs to be monitored. Insomnia based on when you take the medicine. If you are giving the methylphenidate extended, it needs to be taken between 7 to 9. For some reason, it was not taken by 10 o'clock. It should not be given on that day. So you can start the medication on the next day. The onset of action of immediate release methylphenidate in 20 to 60 minutes. Duration of action is 2 to 4 hours. The dose is initially started at 5 milligram to 5 milligram to 10 milligram. It can titrate it up weekly increments of 5 to 10 to the max of 2.1 milligram per kg per day. That is maximum daily dose of 60 milligram in children and 80 milligram per day in adults. The methylphenidate available in multiple formulations. One is immediate release. Second is osmotic release. It's available as Concerta, that is osmotic release oral system, or ORS MPA. The efficacy starts at 1 hour and lasts for 12.5 hours. Another available preparation called Metadate CD, wherein methylphenidate 30% has IR beads and 70% has ER beads, extended release beads. It comes in the capsule, so you cannot break it and give because it has 30% immediate release, 70% extended release. Answer the effect is 1.5 hours and the effect wanes after 7.5 hours. Focalin, other methylphenidate preparation. The duration effect is estimated to be 6.3 to 7.5 hours. The Focalin also available in extended formulation. It's faster onset. The effect lasts for about 12 hours. Ritalin LI. Here, each capsule has half immediate release beads and half is enteric-coated delayed release beads. Duration effect lasts for about 10 to 12 hours. Quilivan XR. It is a suspension form of extended release methylphenidate. It's a different formulation, polystrex polymeric resin compound. The onset starts at 45 minutes and it lasts for 12 hours. Chew, that is chewable methylphenidate. The onset is 45 minutes and it lasts for 8. Let's talk about amphetamines. As we discussed earlier, in patients with ADHD, there is a paucity of neurotransmitters in the synaptic cleft. Amphetamines also acts on the reuptake of neurotransmitters. It blocks the reuptake of dopamine and blocks the reuptake of serotonin and blocks the reuptake of norepinephrine. It blocks all the three. In addition, it inhibits monoamine oxidase and also it promotes the release of neurotransmitter from synaptic vesicle. The side effects of amphetamine are dry mouth, anorexia, weight loss, abdominal pain, nausea, insomnia. It also causes restlessness, emotional lability, dizziness, tachycardia, and risk of abuse and dependence. The most notable ones are anorexia, weight loss, and insomnia. Anorexia weight loss also seen in methylphenidate. I think it is more pronounced with amphetamine salts. Insomnia is common among stimulants, but if you give early in the day for extended release preparation and don't give immediate release preparations after 4 o'clock so that you can avoid insomnia. Emotional lability happens when the effect of amphetamine goes away. In extended preparations in the evening hours typically happens. And also it causes restlessness, dizziness, tachycardia, and risk of abuse and dependence. Contraindications for amphetamines are advanced arteriosclerosis, symptomatic cardiovascular disease, moderate to severe hypertension, hyperthyroidism, and if the patient is allergic to amphetamines, the patient has glaucoma, agitated states, history of drug abuse, and use within 14 days of administration of monoamine oxidase inhibitors. Most of these issues happens in adults, not that common in children. Amphetamine also available as immediate release preparation, and the onset of action is 20 to 60 minutes. It lasts for about 3 to 6 hours. You need to start the dose of 2.5 to 10 milligram daily and titrated at weekly increments of 2.5 to 5 milligram to the max of 20 to 40 milligram daily. It's also available in extended release formulation. Onset of effect is 2 hours. The effect lasts for 12 hours. The Dianabol is the suspension form of amphetamines, especially for children. It has both immediate release and extended release amphetamine components. Onset of effect seen in 1 hour and it lasts for about 13 hours. The lisdexamfetamine is the prodrug of amphetamine. It also blocks the dopamines, blocks norepinephrine, and also acts on the synaptic vesicle to promote the release. It's attached to the amino residue called lysine. It's available in capsules and chewable tablets. The lisdexamfetamine is converted to D-amphetamine, and there is a L-lysine is hydrolyzed by red blood cells, so it prolongs the effect by being attached to the lysine. But the effect of the medicine of lisdexamfetamine comes from D-amphetamine. The dosing is 30 milligram, 50 milligram, 70 milligram once daily. Following administration, conversion of lisdexamfetamine to D-amphetamine occurs approximately 1.5 to 1.5 hours, and the effect lasts for about 13 hours in children and the effect lasts for 14 hours in adults. If the medicine is taken along with food, it prolongs peak plasma concentration by approximately 1 hour. Let's talk about non-stimulants. Atomoxetine was the first one approved in the non-stimulant class. It's available as Strattera. How does atomoxetine work? It blocks the reuptake of norepinephrine from synapse. As a result, there is increased norepinephrine in the synaptic cleft and this causes increased neurotransmission. The dose is 0.5 to 1.4 milligram per kilo, the adults 40 to 100 milligram. It causes sedation, nausea, vomiting, increased heart rate, and increased blood pressure. It also causes irritability, decreases in appetite, and also decreases in growth. It is approved for once or twice daily. It has a black box warning for suicidal ideation and hepatic toxicity. Best to take with food. Twice daily administration may aid in reducing sedation and GI side effects. The time to onset can be seen within weeks in excellent responders. Full effect may not be seen for up to 3 months. As you can see, the article published in 2007, it's a meta-analysis done 7 studies using 1,600 participants, atomoxetine moderately reduced ADHD symptoms. The effect was seen in inattentive symptoms as well as hyperactive and impulsive. The next drug is called Viloxazine. It inhibits norepinephrine reuptake, and also it has a 5-H2C agonism and 5-H2B antagonism. As a result, it improves the hyperactivity and also enhances the impulse control. The Viloxazine is available as Colbury commercially. In children between 6 to 11, the recommended dose is 100 to 200 milligram. In children 12 to 17, the recommended dose is 200 to 400 milligram. It can also cause sedation, difficulty sleeping, and decreased appetite, nausea, vomiting, irritability, and increased heart rate. It's approved in children, improvement often seen by 2 weeks. It's approved as an antidepressant in adults. So in patient with depression with ADHD, so viloxazine can be used. Third group is called among non-stimulants, alpha-2 agonists. There are two. One, non-selective, which is called clonidine, and selective, called guanfacine. Selective means to select two alpha-2 receptors. Non-selective means it works on not only alpha-2A and also works on alpha-2B and imidazoline receptors. As a result, it can cause more sedation with clonidine and more hypotension because of its action on imidazoline receptors. The dose of clonidine often used is 0.1 to 0.4 milligram. It's recommended BID dosing. Side effects are decreased heart rate and blood pressure, hypotension, lightheadedness, dizziness, irritability, dry mouth, and dry eyes. It is approved for monotherapy or combination therapy with stimulants. Sedation can be prominent when initiating therapy or when you increase the dose. Titrate the dose by 0.1 milligram per week to minimize the side effects. Discontinuation should be gradual to avoid rebound hypertension. The discontinuation, the weaning 0.1 milligram per week. The half-life of this medicine is 12 to 16 hours. Drug levels peak at 3 to 5 hours. Guanfacine, selective alpha-2A receptor blocker. It's approved for children 6 to 17 years. The dose often given between 1 to 4 milligram daily. Up to 7 milligram can be given in adolescents. The side effects are sedation, decreased heart rate, blood pressure, hypotension, lightheadedness, dizziness, irritability, dry mouth and dry eyes. It is approved for monotherapy or combination therapy with stimulants. Sedation can be prominent when initiating therapy or raising the dose. Like clonidine, discontinuation should be gradual to avoid rebound hypertension. You need to decrease 1 milligram per week. Bupropion. It's a weak inhibitor of norepinephrine and dopamine reuptake and does not inhibit monoamine oxidase. Bupropion is effective against ADHD but lower efficacy than stimulants. It is useful in the treatment of comorbid ADHD with mood disorders and depression. It is useful in ADHD with substance use disorder. Side effects: agitation, anxiety, decreased appetite, and insomnia. There is slightly increased risk for drug-induced seizures when the dose exceeds 450 milligram per day. Buspirone, it is an anxiolytic agent which binds to serotonin 5-HT1A and 5-HT2 receptors. It also has an effective activity against D2 autoreceptors. It may have a role in the treatment of patients with ADHD and comorbid anxiety. Clinical tips for non-stimulants. ADHD with anxiety disorders, one can use Atomoxetine. ADHD with tic disorder or oppositional defiant disorder, one can use alpha-2 agonists. ADHD with depression and anxiety, one can choose bupropion or relaxacine. ADHD with substance use disorders, non-stimulants. Above recommendations are based on clinical experience, not based on clinical trials. ADHD with sleep disturbances often can be treated with alpha-2 agonists. Then the question always comes to the practitioner, what to start first. In a naive patient, it is reasonable to start with MPH product, methylphenidate product. If the patient has only partial response or unable to tolerate methylphenidate, they can switch to amphetamine product. The next question, especially in children, can the patient swallow a tablet or capsule? If the patient cannot swallow, you have to either use chewable or suspension form. The other question is targeting a specific time of the day. If you're going to use extended release preparation, make sure the patient takes the medication between 7 to 9 a.m. For some reason, if the patient cannot take by 10 a.m. on that day, they have to quit on that day. They can start the medication next day morning. If the patient is getting immediate release preparation for extra boost or some other reason, please do not give after 4 p.m. to avoid insomnia. How to monitor for the long-term effects by stimulants. Growth. The weight can be impacted in the first 12 months and impacted in the first 24 to 30 months. It has an effect on the cardiovascular effects. Arrhythmia, cardiovascular disease. It can cause hypertension, ischemic heart disease, heart failure, pulmonary hypertension. And even though all these effects has been associated with the use of stimulants, no significant effects have been seen with the usage of methylphenidate and amphetamine. These two medications have been used in children and adults for the past 30 years. Cardiovascular effects are very rare and not associated with stimulant use so far. But nevertheless, one has to monitor when the patient is on stimulants, monitor the growth, especially height and weight, and cardiovascular effects like blood pressure and heart rate needs to be monitored every 3 months in the first year. Once it's stable, it can be done every 4 to 6 months from second year onwards. In adults with on stimulants, in addition to blood pressure and heart rate and growth, one has to check EKG and troponin, cardiac enzymes, as a part of monitoring. There are lots of guidelines for ADHD available. Almost every couple of years, one organization or other come up with guidelines for ADHD. We are going to look at some of the network meta-analysis done the usage of stimulants in children and adults. This meta-analysis found stimulants to be highly effective in reducing the symptoms of ADHD. Compared with placebo, as rated by clinicians, amphetamines were associated with the largest improvements in all age groups. Six studies with 2,179 participants, adult 5 studies with 1,521 participants. They found methylphenidate have the largest improvement in youths, moderate effect in adults. On the other hand, extended release guanfacine had moderate improvements in children. Atomoxetine as moderate improvement in all age groups. When you consider benefit to risk ratios, methylphenidate for children, methylphenidate for children and adolescent, and amphetamine for adults can be used. As you can see here, ADHD symptoms as rated by clinicians in children and adolescents. This is the comparable. They compare methylphenidate with stimulants with placebo. Clearly, usage of drugs is favored to control ADHD symptoms. In adults, the same thing. It favors the usage of stimulants or drugs to treat ADHD symptoms. Mean ADHD symptoms rated by teachers. In children and adolescents, usage of drug is favored clearly than placebo. Thus, the ADHD medication has effect on emotional dysregulation. As you can see here, there was meta-analysis done using 13 studies, 2,200 adults. Also, they used lisdexamfetamine. They found small to moderate reduction in symptoms of emotional dysregulation. For atomoxetine, the reduction is small. So, the ADHD medication does improve emotional dysregulation, both methylphenidate and lisdexamfetamine. As you can see, it is against placebo. The use of methylphenidate clearly benefits emotional dysregulation. And also amphetamine salt also favors or helps emotional dysregulation. Atomoxetine also helps the one, but the effect is minimal when compared to lisdexamfetamine and methylphenidate. The next question is usage of stimulant and risk of anxiety. In this particular meta-analysis, using 23 studies, using 2,900 children, they found stimulant medications reduce anxiety by 14% when compared to placebo. As you can see, the overall effect in favor of psychostimulants for anxiety with ADHD. This another meta-analysis of 9 studies with over 1,300 participants found stimulants to be highly effective in reducing aggression, oppositional behavior, and conduct problems in youth with ADHD and conduct disorder, as measured by teachers, and moderately effective as measured by parents. Nevertheless, the usage of stimulants does improve conduct disorder. As you can see, it is measured by teachers in youth with ADHD. The effect of stimulants on aggression, position defiant, and contact problems is clearly favorable when you use medicine when compared to placebo. The same effect was seen when was rated by parents on those three: aggression, oppositional behavior, and contact problems. The usage of stimulants is preferred over not doing anything. Usage of clonidine in opposition defiant contact problems in patients with ADHD again shows usage of clonidine improves those symptoms. Guanfacine has a clear benefit when compared to placebo for ODD with ADHD and also ADHD without ODD. Then the next question is, there are lots of, especially adolescent and young adults, they tend to use the stimulants to improve their performance in education or in preparation for exams. This interesting study was done. Usage of non-medical use of prescribed stimulants in individuals without ADHD, it's associated with lower educational attainment. So it's very important. The ADHD medications need to be given only for ADHD patients. It's a prospective study It's done using 8,300 high school seniors from age 18 to 35. Those who used prescribed stimulant for non-medical usage were 17% less likely to earn bachelor's degree than those who had neither medical or non-medical use. So usage of medication for the performance improvement does not work. The ADHD medications need to be given only for those who are diagnosed to have ADHD. This slide shows the obtaining associated degree and bachelor degrees are less when you give for non-ADHD patients. This concludes the pharmacological treatment for ADHD, and we will have another lecture on non-pharmacological treatment for ADHD. Thank you for listening, and we'll see you next time.